Today I'm going to talk about blood transfusions. Please don't get confused when it says chapter 42. I just have not updated the chapters with the new edition. It is actually going to be chapter 40 in your book. Now remember that 98% of blood comes from volunteer donors. We have all different types of blood products, and you will find those in your book on page 822, table 40-6. And we'll talk a little bit more about that before. But remember, as an RN, one of the things you're going to do very frequently is you are going to administer blood. Now, it is the RN's responsibility to initiate and discontinue blood products. Now, your LPN can monitor during their transfusion and then get the Q and hour vital signs, but only the RN can initiate and discontinue blood transfusions. So please make sure that you're aware of that. Some other things you want to realize is that we have responsibilities before we even start transfusing the blood. One of the first things you want to do is you want to look at their labs. What's their R&R? What's their platelets? What's their PT and INR? The other thing you want to do is you want to check your order. Your order should clearly state the type of blood you're going to give. It should also tell you the amount of blood you're going to give and if there's any special conditions. Some special conditions would be, do they want it over an extended period of time? Do they want you to administer it with a blood warmer? The order should say type and transfuse. Okay? So just realize that. When you're thinking about blood, realize that in a med-surg setting, meaning not an emergency situation, because in emergency situations, such as if they come in through the ER, if they go to surgery, they have different parameters. But for us and for testing purposes, we are considered a med-surg environment. So we have between 2 and 4 hours to administer blood. Okay, 1 unit of blood, that's what you have. So a lot of times the physicians will not state to transfuse it in a certain amount of time. They're going to let you use your nursing judgment. So when you talk about nursing judgment, you got to kind of look at your patient and see what the whole clinical picture is. About 250 mLs are in a bag of blood. So if you have someone comes in and they're only coming in for anemia and that's their only issue, they don't have any other issues, let's say they're younger, they're 27 years old, they could probably handle that blood being transfused into 2 hours versus, let's say you have a elderly person, let's say they're 87 years old and they also have congestive heart failure. Now, they have an order to type and transfuse 1 unit, which is 250 mLs. Now, I need you to start thinking like a nurse, and what do you think happens if we're going to transfuse that blood too fast? That's right, they're going to get overloaded. So in that situation, you probably want to take the whole 4 hours to administer that blood. So those are things that you have to think about. You also want to make sure that your patient has a 20 gauge IV, and the reason that is it's not because blood cannot be started in, let's say, a 22, because I've had lots of people brag about starting blood in a 22. What happens is, evidence shows that when you get smaller than a 20 gauge IV, the only thing that's happening is the blood is actually bursting. And so those red blood cells are bursting. That's in all that plasma that's going in. So the patient never really gets the benefits of those red blood cells. So that is why we want it in a 20 gauge at a minimum. Okay? Once you have your 20 gauge IV, you want to maintain it with normal saline at KVO. And that's because you don't want anything to happen to it from the time you start that IV to the time you go down and get your blood from the blood bank and you come back up and you initiate it. So we just started at KVO. Now KVO, you got to follow your policy, your hospital's policy, but typically it's between 15 mLs an hour to 30 mLs an hour. Also remember, you can only hang normal saline with blood, nothing else. So if a patient comes back from surgery and let's say they have LR going and they have orders for blood, please remember that blood is going to supersede that LR order. Now, once you're done with blood, you can go back, and if they have maintenance fluid of LR going at 75, you can go back and start that. But you can't hang that LR with that blood, only normal saline. Okay. So once you've initiated that you have a 20 gauge IV and that it works, you're going to have to get some baseline vital signs. Okay. And the reason you want that is because that gives you a baseline of where to start from. Because remember, we are always on the lookout for a reaction. We don't want our patient to have a reaction, so we need to kind of realize what's our baseline here. You also want to ask about any history of transfusions. That way we can kind of, if we know they've had reactions before, we can either get up with a doctor and get orders for to pre-medicate them, or we just are more aware of it. Okay, so if something does happen, then we're aware of it and we can follow the proper policy and procedure. So once you've got your vital signs, the other thing you need to make sure that you do is that you need to get a consent for blood. Okay, that has to be done prior to actually starting the blood. Okay. So once you get your blood, you are going to come back upstairs from the blood bank. You need to be the blood has to be verified. Now, I know that we have some of the local hospitals that are verifying different ways. One of them is they're scanning in the computer, but right now, and for your testing purposes, you have to have 2 licensed individuals to verify the blood. And what you're looking for is you're looking to make sure that the name, the ID numbers, the type of blood, the RH factor, that it is the correct product that was ordered. You're also going to look at your expiration date and your expiration time to make sure that you're going to be able to transfuse that blood into that person in your set amount of time. Also, you're checking your blood and you're looking for any type of discoloration. If you have a discoloration, or if your bag is very distended, that lets us know that that bag is probably contaminated and we would not infuse it into the patient. Okay. Also remember, when you get your blood, that you got to have a blood filter. Blood requires its own filter. Now, hospitals vary as far as where they keep them. Some hospitals keep them in a supply closet. Some you get with your blood when you go down to the blood bank, and others have pharmacies send it up. So you got to kind of know what your policy is for your hospital. Okay. So other things you want to look at. I told you to get your vital signs, but also listen to your lung sounds before you start this blood. And the reason that is you want to be on the lookout for any type of fluid overload. So if my lung sounds were clear when I started, or before I started my blood, but then about 2 hours into my blood, my patient starts sounding really wet, then I know that there's some possible fluid overload there. Now remember, in this situation, we really don't want to stop blood unless we absolutely have to, because there's a reason the doctor wrote an order for blood. Okay? So what we would do is we would slow it down. Go call the healthcare provider, and you would anticipate an order for some type of diuretic to help combat the extra fluid that the volume is receiving. That the patient is receiving. So that's what you would anticipate. We don't ever stop blood unless they are truly having a reaction. Okay? The other thing you need to realize is that you never add or infuse any other drug with any blood products. And the reason that is because when you mix that with the blood, there is a potential there for clotting, and we don't want that. Okay, so please be aware of that. In your book on page 823, it talks about transfusions. It starts with transfusion responsibilities. It talks about different types of transfusions. You also have some really awesome charts in here. Your chart 40-12, that walks you through everything a nurse does before she gives blood, during blood administration, and then after the blood has been completed. So that is a great chart. Also, table 40-6, it talks about all the different types of blood components. So please be aware of that. Also remember that one of the biggest issues is our blood has to be compatible. Our patient's blood, I should say, has to be compatible. So remember, you need to be familiar with your ABO compatibility. There is a chart on page 824. It's table 40-7, and it talks about the compatibility of different types of blood. Along with the different types of blood, remember, you also have to look at that RH factor. So please be aware of that. You probably remember that back from OB, or you'll talk about this semester when you talk about high-risk OB. But realize that we like the RH factor to match, and that they have to be compatible blood types for them to be successful. Okay. Now, the other thing you have to realize is you have to educate your patient. You tell them why they're getting blood. You also talk to them about the fact that you've got a consent already. Ask them to give you, if they have any type of signs and symptoms of reaction, to let you know and provide them with some examples of that. Now, there is a great chart that I made that is in Module C that you need to be familiar with. It talks about all the different types of transfusion reactions that are possible. You need to know this. For testing purposes, I will give you, usually I'll give you signs and symptoms of reaction, and I will say, what type of reaction is this? Or I will give you signs and symptoms, and then you need to know what you do for it. That is all laid out perfectly clear for you on that transfusion reaction chart that is in Module C. So you need to know that. Okay. Also remember, once you start with the blood transfusion, you have to remain with that patient for the first 15 to 30 minutes. It's whatever your hospital policy is. It depends on what hospital you're at. The range might change a little bit, but it's 15 to 30 minutes. So that's what you need to stay with them, because we know that they are more likely to have a reaction within that first 50 mLs of blood. So you want to, when you set your transfusion, when you set your pump as to what you want to go at, realize you want at least 50 mLs of blood to get to them within 15 minutes. Because if they're going to have a reaction, you want it to happen while you're in there, because you are most qualified to deal with that patient. And like I said earlier, remember, you have between 2 and 4 hours to transfuse blood. Now, I talked about the types of transfusions a little earlier, and I referred you back to the chart table 40-6 on page 822. We have different types of products, and we give them for different instances. You're probably most familiar with the red blood cells. Okay. And the reason we get packed red blood cells is typically because of blood loss due from surgery or trauma, or they just are anemic. Okay. Platelet transfusions, we will give those to people that have a platelet count of less than 10,000. Okay. Or if we have a patient that has thrombocytopenia, who is actively bleeding, or if we have someone scheduled for an invasive procedure. So those are examples of when we would give platelets. When we talk about FFP, it's also referred to as plasma transfusions, but you'll hear it in clinical practice called FFP. This actually replaces volume. So if all we need is to replace volume, we'll give some FFP. Now, we also can give cryoprecipitate. This is for people that have fibrogen levels of less than 100, and that we just give IV push. And another type of transfusion we can do is something we call white blood cell transfusions. This is typically very controversial right now just because of the potential for an allergic reaction. So our benefit definitely has to outweigh our risk in this type of transfusion. Now, when I talk about self-donation, remember we like self-donation because it eliminates compatibility issues that could arise. Okay. Our most common is our preoperative. This is where the patient will come in and they will donate a little bit each week until they have the amount that is required based on the surgeon's recommendations there. And the good thing is fresh packed red blood cells can be stored for 40 days, or we can even freeze them for up to 10 years. Other type of self-donation that we have acute normovolemic hemodilution. And this is where we remove that patient's red blood cells and we just replace volume prior to surgery. And the reason we do that is because it's actually going to cut down on the number of red blood cells that are lost during surgery. And then we also have intraoperative donation. This is where we recover the patient's own blood and we re-infuse it. Okay. Remember that it has to be reinfused within 6 hours. And then we can do post-operative blood salvage. And typically what we do right here is, again, we have some type of drainage device. A great example of that is something called a Constavac. It's for knee replacements, and what we do is the blood is drained down into these containers, and then after a predetermined amount of time we hang them back up and it's reinfused into the patient. Now your physician will tell you exactly how long to allow drainage before it's reinfused. The thing we have to worry about with post-operative blood salvage is there is a risk for circulatory overload because we're transfusing this blood, and then typically they have other fluids running during and or after surgery. Now remember, I referred you back to your transfusion reactions. Okay, it's talked about on page 824 to 825. I also have that chart for you to look at because you need to be familiar with the type of reactions and being able to recognize those. A few things I like to say: remember your hemolytic, typically those are caused by an ABO-RH incompatibility. That is why it's so important that you know who can get blood from whom I should say, and about your RH factors. Okay? Now allergic reactions, typically these are seen in patients who have a history of allergies. And what's so scary about this is an allergic reaction, it can occur anywhere up to 24 hours following the transfusion. Guys, that's really scary when you think about it. Okay? Febrile reactions, these typically occur in people who have anti-white blood cell antibodies. Okay? Typically, these type of antibodies develop in people who have had multiple blood transfusions. Okay? And then when we look at bacterial reactions, those usually are caused from infusion of contaminated blood, usually with a gram-negative organism. Now, circulatory overload we have to worry about. This is the most common reaction with whole blood transfusions or in someone who's getting multiple transfusions. So it's typically where you've infused blood too quickly. Remember, your older adults at more risk for this. So these are all things that you need to be aware of. Okay? So I always like to give some people pictures because sometimes it just sticks in our head. But these are all the key points that you need to remember either before, during, or after blood administration. Okay?